I remember so many times that I would think about bringing up transport, and I would think, well, once I bring it up, it's going to plant that idea in her head. And what would a really good midwife do right now? Probably not suggest transport. A really good midwife would. And then I would try like all these different things to try to stay away from the hospital. And I told myself it's because that's what she wants. That's what this woman has come to me and paid me thousands of dollars.
Yep.
To make this happen, not at the hospital. That's why she came to me and paid me, right? So I feel all this pressure. And even when I'm watching her suffer, I'm thinking, we're not getting anywhere. I'm thinking the things I'm trying so far aren't working, and I'm starting to get discouraged. And I'm like, don't get discouraged. Stick with it, And even when I would start to see dangerous things, her blood pressure is creeping up. Her blood pressure is really high. Well, we're going to try all kinds of, oh my gosh, I would be like, oh, she's got high blood pressure. Let's chop up some garlic and shove it down her throat. Like, that's going to help, but it was like, well, I read it on the internet and it probably not going to hurt. So let's give it a shot, like try anything, hoping. And there were times when I really felt like I was walking that very, very thin line between, trying to keep her safe on the one hand. Like I was thinking about the hospital and thinking, this could be we could be in danger territory here. This is not 100% normal, versus thinking, like this is, what we've agreed to do. This is what the best outcome would be, that we all stay here and have this beautiful birth. That's the way I'm thinking. So, I'm not sure if I totally answered your question, but
well, it was a very midwife answer to the question that was asked.
Oh no.
Which I think is good, because it demonstrates if that's included in the video that Danielle puts out, it demonstrates how a direct question like, does the distrust of the medical institution make midwives choose not to transfer? And everything that a midwife tells you, they revert it back to how skilled they are and all these tricks they know. And it's really you could be skirting the line, but this is what you want and this is what you chose.
Now, if you had any advice for people looking into a home birth or birth center birth, what would your advice be for them?
Well, most people who are looking into a home birth or birth center birth are not looking for any advice. It's my experience. It's really hard to give unsolicited advice and have it taken seriously. So I would say my only advice is to remain, to listen to people who have been there, I guess. Don't close your ears and say, I don't want to hear any of the negativity. You need to hear it all. You need to hear the positive stories and the negative stories. And then that's the only way you can make an informed decision, is to know, like, truly what are the pros and cons of what I'm doing, not just what am I being told, what do I want to hear, but what is really potentially the outcome here. And if you have read it all and you know it all and you've listened to it and you decide, I'm going to do this anyway, and that's your choice, that's you're free to do that. But a lot of people go into the decision with blinders on, and you got to take those blinders off. That's my only advice, I guess.
Yeah.
So I do have a question. Go ahead. Like, what consequences or backlash have you faced by coming out in the open with some of these truths that you've given, maybe in your community or as a whole? I mean, I know when I first met you was online in a birth group, and I know you faced a lot of backlash from us in particular, but I mean, maybe in your community, coming out and kind of spreading the honest truth instead of just keeping it up to yourself. I mean, you could have just walked away and not told anybody and just, kind of ignored it, turned a blind eye. So just kind of interested in seeing that, where you stand on that. Or
so when I first came out with my story, so I think, oh gosh, was it April of 2016 maybe? That sounds right. So it was toward the end of when I was finishing up my degree, and I finished my honors project, which was basically doing this whole writing project and putting it out there on the internet. When that first happened, I already had lost most of my friends in the midwifery community because they were all good friends with my partners, and I had successfully kind of made enemies of my partners as I was trying to add this other midwife in because I didn't trust them, and they picked up on that. I never told them I want this person to come on because I don't trust you anymore, but they knew that. So I had already lost most of my midwifery friends, but not all of them. And then when it came out on the internet, I was confronted by one of the grand midwives. So this is a person who is extremely established in this community. Her name is Amy Medwin. She's known for operating, I did not make this up, a harem of midwives who do illegal births. So, because in North Carolina, there are no legal CPM attended births at all. So this is the woman who will take on your twins and your breeches, and there are no legal like things that she has to adhere to. VBACs, no problem. And she is famous for agreeing to attend your birth and then just sending a couple of her assistants, and then, oops, I didn't make it, but I still get most of the money. So, so she actually confronted me over the phone and over email, or maybe it was a chat. I don't really remember, but she was just like, how dare you air our dirty laundry? We could have taken care of this all in-house. You should have brought this to the community and we would have dealt with it. And, now what you've done is blah, 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 blah. She just really tore into me. And I was like, Amy, I don't care what your opinion is. So, I'm not taking it down. And so any remaining allies or friends that I had in that community who were actually working in that community, I haven't, I had to make new friends, basically. I had to make all new friends. But the moms, that's a different story. A lot of them came to me privately and they were like, even though I had a nice birth with you, I have wondered if it was a good decision. Or something like, when I transported and everything, I'm really, really glad that you transported me because now I know what could have happened if you hadn't. So most of them never said a word to me, and I don't know how they feel. And that does weigh on me sometimes. And I sometimes think about, should I send her a message and ask her, like, do you still like me? But I don't do that because I feel like that's up to them. If they want to come to me and they want to say, let's reconnect, let's talk about old times. If they want to tell me, I think what you did was crappy, you betrayed all of us. And, or if they want to tell me, wow, you were such a charlatan, I can't believe I trusted you to deliver my baby. Whatever they're feeling, like, I welcome it. I would love to hear from a lot of them. So I've heard from some. I've had some that really reached out to me and thanked me and were really warm and wonderful. I've had others that have been kind of like, yeah, I read what you said, disagree, but I still love you. And it's like, okay, that's fair. I've had a couple that maybe they posted something that I'm like, okay, this is about me, but didn't really confront me directly. So overall, I would say I had some good responses from the community. Mostly I was kicked out. Mostly I had to find new friends. But the people that I've made friends with since, I'm really actually super glad. They're more diverse. And I would say overall, I hate to say more educated because I had plenty of very educated clients, but I guess they're more, maybe a little bit more open-minded, and not just on kind of one track, like kind of the the wellness track, which I put that in air quotes because it's not always about wellness. It's about fitting into a certain particular wellness community of people. And that's a very different concept than just help. So.
Mm-hmm.
So if you kind of building off of that question, if you knew right now or whenever this gets posted on YouTube that a midwife who is questioning her career or his career, somebody who's really like, I got into this because I wanted to be part of these beautiful, natural, empowering births, but they're starting to see kind of the dark side of what happens and how things get brushed under the rug. What advice would you give to a midwife or doula who's kind of on the precipice of turning their back on their career for the sake of saving other people's children?
So it definitely does not escape me that I was in a privileged position to be able to walk away from my career. Although I was making a lot of money as a midwife, my husband was making enough to support both of us and our children. And I never had to worry about paying my mortgage or where my next meal was coming from the way that some people would if they were going to leave the profession. So the profession, I hate that, whatever you want to call it.
The club. It's a club.
Even the club, the very lucrative club that they're in. So I understand that the decision isn't always as easy as just saying, you know what, I'm going to do something else. I'm going to go back to college and start a new career. It's not always that easy. But it's definitely, if you're not a nurse midwife, if you're not medically trained, then you shouldn't be practicing what is essentially a medical career in a low resource setting. And once you accept that, you have to find something else. You have to find a different path. So I think, stop lying to yourself. I mean, I think that I told myself a lot of, I reassured myself, oh, you're not like those other midwives. You're doing it right. You're doing it better. But it's only so far you can go. You are still, you've got people's lives in your hands who the reason that they're there is because they have not been given a full picture of what they've decided to do. And you are profiting off of an industry that perpetuates untruths about the safety of birth in different environments. So, yeah, I mean, as far as how you get out, I mean, that's so individual. It depends on your circumstances. If you have to go live with your parents, if you have to, go on welfare for a little while, if you have to, whatever you have to do, if you're lucky like me, go back to school, get a different career, find something that is legitimate that you can do. If you can't do that, then maybe you can wait some tables. It's a tough economy. It's rough, but if you can find your way out in any way, then that's the right thing to do. And if you want to be a midwife, go to school, go to nursing school, apply to certified nurse midwife program, get your training, and go work in a hospital and really actually keep mothers and babies safe and provide legitimate care. And if you're not willing to do that, and if you can't do that, then you've got to stop being a midwife. That's all there is to it. You have to stop.
So can I ask you what the average, income you pulled from let's just say one birthing or laboring person? I know with the business side, you probably had to pay that, but how much did you charge one birthing person?
It's easier than you might think for me to answer that because the way that we structured the birth center was that there was a midwife fee that we received for each birth. So the amount that they paid the birth center, that might be different depending on their insurance, blah, blah, blah. There's a lot that goes into it. And you've got, the cost of doing business and all this kind of stuff. But I know that I cleared $2,000 for every birth that I did. In addition, I made $500 for every time I attended as a second midwife. So, and that's with me having no costs, because that was all rolled into the facility fee paid to the birth center. Now, I do believe we took a pay cut for Medicaid clients. So that was something that each midwife had to decide for herself. Are you going to take Medicaid clients? How many are you willing to take? And I believe we got $1,200. So it was still a decent payday for very decent, much more than actually doctors get per birth, which is, yeah. Because I didn't have to pay the kind of medical malpractice that a doctor would. So that $2,000 was straight into my pocket for each birth. And I was doing 4, maybe 5 births a month. Some of the midwives were doing 8. So yeah, very decent, very, very decent income for someone who doesn't have student loans to pay back and all that. So now, it's gone. So I don't, it wasn't a situation where I built up any kind of major nest egg or anything like that. And maybe part of that was because I never foresaw it as being a real money-making venture. Everybody always makes that joke, like, oh, no one goes into midwifery for the money. But once I got into it, the money was actually very good, very good. So, my experience was not that we worked for peanuts or that we're trading, chickens for births or anything like that.
Well, I did have one question, partly because midwives have a tendency to let things slide. And this is also inspired by the Caroline Lovell story. And that is, as if you get a second time pregnant person and they are not exactly truthful and not forthcoming with their records of their previous pregnancies and births, did you pursue those records with due diligence, or did you just, sounds good?
So I know the Caroline Lovell story, but I'm not exactly sure what you're referring to in terms of what.
She had her first birth. She had a serious postpartum hemorrhage, and this was known to her. Her midwives never actually dug up her records, and she died of a postpartum hemorrhage.
Right. So if someone came to me and said that they had had a hemorrhage for their first birth, a few things. First of all, I would feel like it's my job to reassure them that, number one, just because you had one the first time doesn't mean you'll have one this time. Number two, if you do, I know exactly what to do for that. And it was an article of faith, I guess, that, you don't hold something like that against someone. You don't tell someone that they shouldn't have their birth of their dreams just because something bad happened last time. That bad thing probably happened because of interventions. So as long as you don't do those interventions, you don't have to worry about that. So I never had anyone try to hide their obstetric history from me. I usually would just ask them how their birth went, and we would kind of talk about it. And if they said, like, I'm kind of worried I might have a hemorrhage again like I did last time, I felt it was my job to reassure them, not to lend any credence to the idea that, oh, yeah, maybe your body is faulty and you shouldn't have the birth of your dreams. I mean, that would be antithetical to what midwives represent. So no, it was my job to reassure them that whatever happened last time, that's not going to stand in your way.
That is perfect midwife response, by the way.
Yeah, thank you.
Building off of that, is there any complication that you would be like we know, if I'm not mistaken, shoulder dystocia is more likely to occur in subsequent pregnancies after it's already happened. Mm-hmm. If a woman came in or a birthing parent came in and said that they had a history of shoulder dystocia, would you be like, well, no, that's something that might happen again, so you should be in a hospital?
If someone came to me when I was practicing as a midwife and said, last time I had a shoulder dystocia, I would have said, well, first of all, doctors will often call something a shoulder dystocia when really it was just something like sticky shoulders. That's what we call it, sticky shoulders. It's not really that big of a deal. If your baby's okay now, it's probably just sticky shoulders, not a true shoulder dystocia. Now, if you do have a shoulder dystocia, I know exactly how to handle that. All we're going to do is change your position, and it works every time. We're going to use something, called the Gaskin maneuver, and we're going to have you get on all fours, and the baby is just going to pop right out. So you don't really have to worry about that. The reason they can't use that in the hospital is because you're usually all doped up on an epidural, and you can't move your body around. So they actually created the situation that probably caused those sticky shoulders. We're not going to do that.
It's so gross. You sound just like my midwife. Like, I've seen the email she has sent people after they have babies with shoulder dystocia at her birth house. And literally that's exactly what she says is like, in an intervention situation, this would have been so much worse. And next time it'll be no problem.
Right.
Whew.
And the double edge of that is when people read that, they have a distrust of the medical community and possibly begin to doubt the care that they got in their first birth or their second birth or whatever birth that's, caused them to come to the birth center. They begin to doubt it. And they're like, well, I really didn't need that. See, or I could have, I could have had a breech baby. Look, breech is a lost art or whatever, that they just go down that route and they forget. Well, maybe they just don't even realize that the reason why vaginal breech is gone is because of all the data that, we knew how to do it. And as soon as C-sections became safer, had a less chance of, had better outcomes than the breech birth when they compared outcomes, then all doctors switched to C-sections. Because C-sections did actually have come a long way and have a lot of a different protocol than even if I would have had one. And definitely if my mother would have had one, it's just just like everything in medicine. So that's the true tragedy, frustration, whatever you want to say of those responses.
Well, we no longer live in a time where we need harrowing stories of these midwives doing crazy maneuvers because we have technology, we have hospitals, we have science. There is no need for a baby to be born in a situation that could risk its life when down the hall you should have an operating theater to get that baby out safely.
And a qualified NICU team to attend that baby for resuscitation.
When you were still actively doing out-of-hospital births, when you would have complicated deliveries that could potentially result in harm to the baby or mother, or the birthing parent, how often would you refer those clients and patients out to specialists or pediatricians to have them evaluated properly once the baby is born?
So you're talking about a birth that is complicated but completed in the out-of-hospital environment?
Yes.
Okay. So I know that in school, that's where I saw most of those. I didn't end up with too many rough births that I didn't transport once I was practicing on my own. So right now, I can't think of any situations where I referred out due to a rough birth. Due to some suspected possible anomalies, I would always tell them to take their baby to the pediatrician sooner rather than later, like the next day. In Miami, on the other hand, we had a lot of really rough births and we almost never referred out.
So like a baby who was born at the center down in Miami, say they were born with shoulder dystocia and needed resuscitation afterwards, would they ever be sent to a neurologist or a physical therapist or anyone to evaluate the longevity of that baby's health and safety?
Rarely. If we suspected the baby had a broken collarbone or something like that, we would say you can take them in, or we can just kind of like swaddle them and it'll heal. I mean, so rarely. And I remember, so I was at one birth where the baby, this was in Miami, the baby was born with ambiguous genitalia. And so that was one of the only anomalies, birth anomalies that I saw actually. And so we couldn't tell at first glance if the baby was a boy or a girl. And I remember that I was really terrified that the midwife was not going to send them anywhere for medical evaluation. And I saw that she was going to do the newborn exam and that she was looking for the urethra, and the way she was talking and everything, I was like thinking to myself, she's not going to send this baby anywhere. And I felt like the baby needed to be evaluated. So I remember that I took a really big chance and pulled the father of the baby aside and said something to him about taking that baby to see someone soon. Like I don't know if I said, I think when you leave here, you should take this baby to the hospital, or if I said to a doctor. I don't remember exactly what I said, but I remember that I told him that, and I was trying to kind of hedge, like I didn't want to say anything that would get me kicked out of school. But I also really didn't trust that midwife to tell them to take that baby and to be seen. I mean, we didn't know if there were any other anomalies. We didn't know if this was just a cosmetic issue or if there was something going on that needed treatment. And I felt really uncomfortable with that. So, and I remember that she did leave it up to the family, but she kind of was like, yeah, you could take the baby in or not, it's not life threatening. But I was like, well, do you know that it's not, or do you just think it probably isn't? And you're just saying that, you're not qualified to actually say that, I don't think. So
you're not a geneticist, so you don't really know what is at play causing that. And that's a problem that maybe it's a one thing, but it's also one of those problems that they do tend to stack when you have anomalies happening like that on the outside. It very often can be indicative of deeper issues within the baby.
And that's what I was worried about as a student. I was worried that there was something else wrong, or that there was something like there was going to be a problem with maybe the baby not being able to urinate, for example, or something. I didn't know what could be wrong, but I felt like it wasn't up to us at the birth center to decide if the baby was okay or not. So yeah, I would say we very rarely referred out, even when the birth was rough. We kind of explained it away by saying, well, we give vitamin K injections, so that makes it okay. If the baby had a rough birth, this will fix it.
What was the, when you say rough births, I assume that you did see newborns that required, shall we say, more than the usual amount of attention. What was the worst you saw there?
So the worst I ever saw, oh my gosh. So this baby was born floppy, is what we would say. Basically no muscle tone, not trying to breathe, eyes just closed. And the older student midwife, I was a pretty new student midwife at that point. So the older student midwife was listening with the stethoscope, and she said, I don't hear anything. So we thought the baby had no heartbeat. And so we started chest compressions. I wasn't the one doing it. Someone else was doing the chest compressions, and then she was listening and saying she didn't hear anything. And then at some point, they asked me to take over the listening part. So I put her stethoscope, I took it from her and put it on, and I was listening. And immediately I thought, this is very strange. I don't hear anything. I should be hearing something. And I picked it up and I tapped on it, and I still couldn't hear my tapping. And I realized that the stethoscope was turned the wrong way. So I turned it around and I put it back on, and I'm like, 150. His heartbeat was racing. So he needed some more help breathing. But the heartbeat was there and it was fine. But I remember thinking that, we were in a no heartbeat situation for a while there. And this all happened very quickly. And I don't have like an actual timeline to give you. I don't have access to that. But I do remember thinking how shoddy that operation was. Yeah. Did I answer the question? I don't. I might have gotten off track.
In a way. You saw a limp. Was the color good or not?
No.
Purple, gray,
like pale, just a pale.
pale skin.
I can't remember that baby's skin color, but I do know that we had a very, like a very diverse client base. I mean, if any of you have been to Miami, you know that it's a very diverse city. And so we had people from all over the world, like very international clientele. We had everyone from Medicaid people to people who flew private jets in to have their babies at that birth center. So I'm pretty sure that baby was a darker skin tone, so it's a little bit harder to tell. But what I do remember very vividly was the lack of tone. So if the baby was, it would have been not a good color. But yeah, it's sometimes hard to tell depending on what color the baby comes out.
Yeah.
But you could have checked for a cord pulse. You could have checked for a brachial pulse. I mean, there's other ways to check to see if the baby has a heartbeat.
Oh yeah. I'm sure the mistakes could fill a book.
Yeah, and that's the whole point of me saying, we do this every day at my work, right? So we're skilled because we practice all the time, right? We practice in sim labs, we practice on patients. In a birth center, how often does that happen, right? And so you lack skills just because you're not in practice, and that's what I try to explain to people. That's a huge, huge difference.
Absolutely, because even the busiest midwife is maybe doing 8 births a month. That's not enough to see those kinds of complications often enough to stay on top of your skills. So, yeah.
Well, we've heard in the past, I've talked to other families and was like, how did you pick your midwife? And other ones were like, oh, my midwife had 100 births, or my midwife had 150 or 200. So you think like that's a lot, whatever, but it's actually not a lot. And one of our things that we were talking about one day, Karen said that an OB sees an average of like 8 people in like an hour. And I was like, holy crap, that's a lot of babies. Like, you don't really actually think about it, but so actually saying that, like, it makes sense. You're like, oh, 50, 100, that's a lot. But it's like, no, actually, that's not a lot at all compared to what's really going on, like, in hospitals. So,
yeah, but to a layperson, it really does sound like a lot. Like I told you that my doula had attended 5 births. And from my perspective, I thought she knew it all. I thought she was so experienced because I had attended 0. So obviously that's 500% more or whatever, it's like, it's not even good math, but yeah, to a layperson, 100 births sounds very impressive. Even 50, it's like, oh, she knows what she's doing.
I have a cousin, and her boyfriend are both in their residencies downstate in Staten Island, and neither of them is doing an OB residency. Neither of them, after their clinicals, went into this kind of work. And even in just their clinicals, before they decided which path to become a doctor they wanted to take, they saw more than 100 births. They're like, yeah, and they're like 2-3 weeks we were down there. We caught babies left and right. There was just babies everywhere. And it's just shocking when you think that the people that we're being told to distrust, the people that we're supposed to think are just super against us and not on our side, they're the ones who have seen the most and deal with the most. And they're the ones who deal with the repercussions of the decisions that we make when we choose home birth midwifery. So obviously hindsight is 2020, but like looking back on it, it's shocking to me when we're like, yeah, doula's been there. She's not even a medical professional, but I'm going to be totally fine because my doula has seen 50 babies get born.
Yeah. What you reminded me of just now is that we had an office manager at the birth center, and she at some point decided that she was entitled to attend births. And she was like, well, I'm going to become a doula. And most of the people were like, okay, great. I was like, oh, just what we need, another doula. We need an office manager full time, but what can I do? So she started attending as a doula. And before you know it, of course, she's accidentally, oops, I didn't call the midwife on time. I caught the baby at the birth center. She had no training. She had no credential except for she was a decent office manager. But I remember her talking in one of our staff meetings about how unfair it is that she should be so close to these miracles happening and not get to participate. That's just cruel to her. And she just felt so entitled to be involved and to be in that room, and even to go as far as catching babies herself. And of course, I don't know to what degree that was an accident, but she claims it was, but who knows? But she definitely bragged about it afterward, So yeah, that kind of, it was like, if that could happen to the office manager, I'm sure that happens to most doulas.
One of the birth assistants when I was in labor was the office, not even the office manager, the full-time office assistant. Mm-hmm. And so I think that must be a theme. Is that a theme in midwifery? Is you like hire assistants to like help you shuffle paperwork, and then like 6 months later they're catching babies in your parking lot because you told people to stay home too long? Like I thought it was mine, but apparently this is just like how you move through midwifery.
I think most of them start out as assistants thinking that they're going to catch the babies, but you may be onto something. There may be another subset of people that get into it because they get hired as clerical or some kind of other support staff. And then they're like, if she can do it, I can do it too. And they just kind of move into it.
I have a question, and you can give a 2-part answer because I would be interested in both answers. You said that once you moved and you were doing your own practice, you weren't taking, I think you said VBACs, you couldn't do breech. There were certain conditions that you wouldn't take on. What conditions in a mother's history would you be willing to take on? And which ones would you not take on, and would you refer to an OB? And I am interested because I get the feeling that you probably had a stricter set of parameters once you moved and were on your own. So I would like to see what the education side of thing is, educating midwives to be willing to take on as well.
Yeah. So, there's a few layers, there's the layer of what's legal for you to take on. And there are legal parameters in both states, in Florida and in South Carolina, saying that, like a woman has to meet these criteria in order for you to take her on. And so if they showed up at my door and they met all the criteria and I decided to take them on, that's the point at which after you've established care, things can get a little bit gray, because you're not supposed to take someone on who has high blood pressure. But if they develop slightly high blood pressure and you're trying to manage it, it's like you have to send them for a consult. But if their blood pressure doesn't happen to be high at the consult, then maybe they still get that, they get signed off on. Or maybe the consult already occurred at 36 weeks, and now at 38 weeks, they're suddenly got high blood pressure. And so the law isn't necessarily as cut and dry of a guidance. So that's when it becomes kind of like your own personal set of what's correct here. And unfortunately, I will tell you that a lot of it was colored by my feelings. Sometimes if I really, really liked someone, then I would be more inclined to be like, oh, let's try everything before we send you to see someone else. Whereas if I didn't have as strong of a connection with someone, sometimes I'd be kind of like, well, your blood pressure is pretty darn high. Let's go ahead and send you out the door. So, I mean, that's really sounds terrible, but it's the truth. So you're asking like what specific conditions, I mean, things like underlying things like diabetes. There were things like obesity, where she would have to go see a doctor who would say, you can be reasonably expected to have, a safe birth, or not. And so it would depend on what doctor you sent them to and their specific medical situation. I remember that there were some people who perhaps they had an issue with blood pressure or with their weight gain, who I would be willing to take on, but only if they would agree to certain like behavior, lifestyle type things. And, agree that if they didn't get that under control, that they would have to transfer care, things like that. So, so a lot of that, it's kind of like, there's some gray area, like D cells in labor. If a baby's having heart rate D cells in labor, at what point do you make the call that this isn't normal anymore?
That's actually one of the questions I've had written down for a week is how long in a labor would it take you? Here's a concern. Mm-hmm. Let's monitor it. Now it's an emergency. We have to call. What's the time frame of that? Because calling the ambulance takes a certain amount of time to get there, but you have to make the call in the first place.
Yeah. Unfortunately, there's no way for me to answer that question because it's so individual to what's going on. And a lot of it, so much of it depends on almost an intuition, which, isn't, I feel like it's better to always make a decision based on facts. But sometimes the truth is, we're looking at the facts and making an intuitive decision of, I feel like this baby's really in danger versus I feel like we're going to get this baby out and it's going to be okay. And who knows what all goes into that, I am not no human knows their own psychology so well that they can say for absolute sure everything that went into a decision. I mentioned before, like how much I liked someone or how much I respected someone could color what decision I would make. And that's the truth in an emergency situation too. So you start to hear some D cells. You're like, well, let's try this. Let's try that. Some of that's legit. The first thing that they do in the hospital is change positions and see how that affects the baby's heart rate. It's okay to do that to some extent. But it depends on just how bad was that D cell, and how long did it last and how quickly did we get it back up? And then we have to listen more often. Are we listening often enough? So yeah, I would have to say that I would, and it also depends on the mother. If the mother is like, in my case, I know if a mother is saying, I want to go, I would be very unlikely to say, oh, we're not going anywhere. Like I never did that. But there are midwives who do, who feel like that's their job, is to tell you, you do not need to go. You should stay here. So that's a difference. I think that some of the birth stories I hear, I'm kind of like, okay, that's the line I wouldn't have crossed right there.
Yeah.
But I mean, when I hear stories like yours, I do have a hard time. Like, I'm like, at that point, I'm like, I want to talk to these midwives and be like, what were you thinking?
Well, my labor was also 16 hours and I pushed for 12. So it's like a long drawn out. But so back to the question that I originally asked you about the conditions in a mother's history. When you're vetting clients, you're deciding whether or not you want to take on the potential liability of their birth. Yeah. Was there anything that your school taught you? Do not take on clients with this. This is dangerous territory. Or was it more of you have to decide once you are on your own what you're comfortable with?
Yeah, they taught us to basically look at the laws of the area we were practicing and to go by that. So there are things like a prior classical C-section, prior uterine surgery. Like let's say you had a bunch of fibroids removed, and you were on an unpregnant uterus. Once you cut that open, you're probably never going to have a vaginal birth safely. So things like that would definitely disqualify you. And then there were the things that it was kind of like, this doesn't disqualify someone, but you should probably pay extra attention to it. Things like advanced maternal age, or like a very, very young client. So those were things that it was kind of like, to a certain extent, left up to your own discretion, whether or not that's something that you want to take on. And they would tell you, you're like, when you first start out, you'll only want to take on these people. But as you gain an experience, you can take on more and more until you're taking on just about anything that you can imagine. So, and that was the goal, to be that ultimate midwife who would take anyone. Like that was the mythical ultimate midwife, someone who would not tell anyone no.
That's when you've like leveled all the way up. You've reached your final Pokemon form, is when you're that midwife.
But unfortunately, that's Lisa Barrett. We already have those. Yeah. And they sadly kill babies. So, I mean, that's the thing, is you can level up, but there's that cost, and which is erased and, like we say, buried twice.